Well, hello everyone. Welcome into March of 2021. Great to have you join us for SADS Facebook Live episode number 54. I'm Mike Ackerman, genetic cardiologist here at the Mayo Clinic in Rochester, Minnesota, which I don't know if you noticed was just named this week by Newsweek the #1 hospital in the world. You won't find any disagreement with that conclusion from me. This is an incredible place to be, and it's also great to get to be with each of you. I'm a genetic cardiologist here at the Mayo Clinic and director of our Winland Smith Rice Genetic Heart Rhythm Clinic and our Sudden Death Genomics Laboratory. But today I'm here with you on behalf of Alice Laura, the CEO and my boss of our Sudden Arrhythmia Death Syndrome, the SADS Foundation, for which I've also had the privilege to serve as president of the board for many years now. And today's topic is a really important one on pregnancy for our women who have one of our genetic heart diseases that we support from the SADS Foundation. And I think you're going to find the news good news. And so in short order, I'll be joined by Suzy from Kalamazoo, Michigan, who will tell us her story. And I'm really pleased to have Dr. Danna Spears from Toronto and talking to us about her experiences as she's taken care of and counseled women with genetic heart diseases who are pregnant. And so before we do that, also good news on the COVID-19 pandemic front. Welcome across the world. I think we have turned the corner, don't you? So let me show you this. This being here, we are now at a number of cases, still a lot in the United States, but 67,000 cases yesterday. The last time we were that low was 5 months ago in October. So hang in there, everybody. Do all the right things. So I don't think you need a mandate. I don't need one to wear this. I just finished a 2-hour lecture in our medical school. We just had our medical students back on campus, socially distanced, but now doing live campus education. So school is back in session. So wear your mask, be socially distanced, wash your hands. Remember the alcohol drill as in 60% plus. Do that. When it's your turn to get the vaccine, get the vaccine. I got mine, as you know, back in January. I got the Pfizer one. Which one should you get? Yes, whichever one. We have 3 approved in the United States now, Pfizer's, Moderna's, and most recently Johnson & Johnson's. So they are absolutely QT safe, the vaccines. They're safe for anybody with any of our genetic heart diseases. In addition, I think we have good news. Despite there potentially having been theoretical concerns that the SARS-CoV-2 virus infecting the heart of somebody with, say, hypertrophic cardiomyopathy or long QT syndrome could be agitating to the heart and make the heart disease worse, we have just not seen that. So it's been a year now, and I don't have a single patient in my practice, over 3,000 patients with genetic heart diseases, where there's been awareness or occurrence that their SARS-CoV-2 infection, and now some have been infected, have had significant or even moderate myocardial injury, just not seeing it. So that's great news. So you're not at increased risk of a bad heart issue from a SARS-CoV-2 infection. When it's your time to get the SARS-CoV-2 COVID-19 vaccine, get it. It's safe. And let's continue to get past and get through the pandemic, which has claimed so far 2.57 million lives worldwide, 520,563 individuals in the United States. So still, obviously, a wow, big deal. It has been a big deal, tragic for families throughout the world. But good news starting to come out. 82 million people in the United States vaccinated so far, and now we're tracking at about 2 million vaccines a day. Well, that's the update on the COVID-19 front and COVID-19 and genetic heart disease. And I see some of our regulars popping in. And now I've been aware this last week that there's many of you who are my patients who don't even ping a comment that you're online watching. So all of you, whether I have the privilege of caring for you directly or indirectly through SADS Facebook Live, it's great to have you be a part of this. With that, let's have Erin, our magic IT person. She's just amazing. Bring on Suzy Berndt. Suzy is a delightful person. And there she is. Look at that. Suzy from Kalamazoo, Michigan. And we're going to be talking about her pregnancy and her experience. But before we do, I thought I'd have Suzy share a little bit of her journey with her genetic heart disease, when it was discovered, what kind it is, what has been its behavior or expression in her, and then bring us to how she navigated with her healthcare team through her pregnancy, where she now has a beautiful daughter, 10 months old. Congratulations, Suzy.
Thank you, Dr. Ackerman.
So welcome. And Suzy, tell us your long QT journey.
Well, it has been as long as I've been alive. I was diagnosed when I was born 35 years ago. I am one of the earlier ones, I believe, to be caught at that young age.
Wow.
It was a lot of good happenstance. I was born in Ann Arbor, Michigan in 1986, and I was born across town from the University of Michigan Mott Children's Hospital, and I was zipped across town by ambulance after I was born because I came out as a very distressed baby, and they knew what they were looking at. They happened to know that this was long QT that they were seeing, and so they put in a pacemaker right on that same day I was born, and a temporary one, and then later I got a permanent one, and was put on a beta blocker right away. And so. Yeah, I think I'm very fortunate.
Do you remember who cared for you back as a child there at University of Michigan?
Well, I'm pretty sure it was Dr. Dick.
Yeah, I thought it was. And so a shout out to Dr. Dick. And in fact, I don't know if people can see it, but there's his picture right up there in the corner when Dr. Dick invited me to be a visiting professor at University of Michigan. And so
that's awesome.
I thought he cared for you. Just an incredible person and an incredible gentleman. And very, very funny, Dr.
Yes.
So you're diagnosed as a child, you're diagnosed as an infant. And then when did you know what kind of long QT syndrome you had?
I don't remember, to be honest. I don't remember when that was diagnosed. My whole family went through genetic testing. We are members of Dr. Moss's study, his registry, and everyone's been tested, and I'm de novo. I'm the only one in the family who has it. And so I think it was sometime in the 90s that we understood what type I had.
Yes, because your type of being type 2 long QT syndrome, whether it's inherited or de novo, the LQT2 gene was first published and discovered in 1995. So it was sometime after that in which they probably called your family and said, you know, we've known Suzy's been long QT syndrome out of the gate, but now we get to call it LQT2, probably since you were about, if I'm doing my math right, 12 years old or so.
Yes, and I suspect I had original testing through Dr. Moss's study because it probably wasn't widely available at that time. When I was older in my 20s, I was a patient of Dr. Cantor down at Duke, and he had me retested because I suspect there was some updated information out there. So we were able to confirm it.
Right, because clinically available genetic testing for long QT syndrome first happened in 2003.
Still so new.
Yeah. So what was it like then in terms of how did the long QT, after you got your pacemaker and so forth, how did it behave during childhood, during adolescence? And then we'll get ourselves towards a year ago with the news that I'm pregnant.
Well, it was growing up, I actually didn't have any incidents of long QT any episodes. So knock on wood, I've done well since birth in that regard. Most of my complications happened related to my device or to side effects from the beta blocker. So as a child, when I was young, when I would get sick with a fever, as most children do, they don't want to eat. And so I would have really low blood sugar, and I'd have to be admitted to the hospital for that. There was a few times. There were some pretty scary calls, I think, in that regard. But
Yeah.
we went through them. We got through it.
Yeah, and we'll pause there just a second, and then we'll jump to present tense with pregnancy. But just to share with everybody, the low blood sugar beta blocker reaction that Suzy's describing is known. We published this a few years ago now. It's very uncommon overall. It's less than a 5% chance of having the low blood sugar reaction. It is most common during a child's first 5 years of life when they may not have a lot of sugar reserves. And the most common connection has been not eating well the night before, but still getting their nighttime beta blocker. And then by morning, having the sugar level having tanked and in the basement. It can be very significant, have to go to the ICU with low blood sugar seizures. But it's interesting now that we know a lot more about it. I can't think of the last time a child of mine on beta blocker has had the beta blocker hypoglycemia. I think it's been over 5 years since our last episode. So I'm glad it was recognized and treated in you. I'm glad the LQT2 has been mostly lifelong dormant. And then bring us to our conversation of the day of I'm pregnant, and what has been that sort of 20-month journey so far of your 9 months of pregnancy, delivery, and the first 10 months postpartum.
Well, growing up, again, I was, raised in an era where we were still learning a lot about long QT, and so I was told growing up that it was something maybe I shouldn't consider, being pregnant, that it might be too risky for my health. But as I became older and the science advanced, I was reassured by everyone taking care of me that this is pretty safe. Actually, we'll be cautious and we'll keep an eye on things, but go ahead and do this if this is what you want to do. And the thing we started to be looking out for is whether I would pass it on, and that became more of what the concern was. So I became pregnant in August or September 2019, and I went through the 20-week ultrasound with Gabby, and there were no findings, and it was great, and we were really excited. And we had an appointment with the University of Wisconsin to have our fetal echo research study participation. And so we were looking forward to that to kind of confirm more details one way or another. But it just happened to be that at the 20-week ultrasound, they didn't get clear enough photos of her heart. And so we had to go back at 24 weeks. And it was during that ultrasound that they found she had second-degree heart block in utero. And her heart rate was quite low. And the MFM team at Bronson here in Kalamazoo were excellent. And they said, let's not panic and let's just watch this heart rate. And, I was referred to U of M for all kinds of fetal imaging and fetal echoes and monitoring of myself. And sure enough, we were able to see her progress. And I guess to make a 9-month story shorter, she kind of declared herself a couple weeks earlier than we had planned, and she was delivered on May 1st via C-section, and we had enough time though to plan ahead that Dr. Bradley at U of M was able to coordinate a lot of people to be ready for her birth, so that we could anticipate whatever her needs might be at that moment. As for myself, my pregnancy was completely uneventful. The biggest challenge for me was when my hip felt really painful because I was carrying a baby, which is pretty standard, I think, for many pregnant women.
Well, Suzy, thanks a lot for that story. And you've given us a lot of items that I want to now have Dr. Danna Spears from Toronto join us. so that the three of us can kind of unpack several of those issues. And here's Dr. Spears. So, Danna, welcome to SADS Facebook Live. Danna is an electrophysiologist practicing in the University Health Network in Toronto, Canada. She is very involved with their genetic heart disease program, their inherited arrhythmia program. And Danna, I think one of the first things I heard her say that caught my attention was, maybe you shouldn't become a mom. And I think that's the one I'd like you to comment on first, because I have heard that one so many times, told to so many of my patients who thankfully have become beautiful mothers of beautiful children, that has made me so frustrated I pulled all my hair out. I think that message that still continues. I might be able to accept it when you were told it, Suzy, but unfortunately it still continues, and I find it bordering totally on cruelty. What's been your experience, up north with that still old, incorrect messaging happening?
Well, it's true. We still encounter women who have been given this message when they're entering their reproductive years. And I think that this is a problem because these are generally, in the general community, these are pretty rare and infrequent diagnoses to encounter when you're a family doctor or an obstetrician or someone who's counseling women on pregnancy. And unfortunately, when you're in a center without adequate experience or support for these conditions, it's frightening. And I think that that message gets to women on that basis. It's more the fear of the unknown and lack of experience in many cases that really drive this message to women that it may not be safe for them to have a baby. And as you have alluded to, there are very, very few cardiac contraindications to pregnancy. And these inherited heart conditions are generally not among them. And we've had many, many successful pregnancies through our program with these inherited heart conditions, with obviously a lot of monitoring and care, but the outcomes are excellent. And I think that that's an important message, that if women, want to seek a family and pregnancy, finding the right specialty support can make a huge difference, both in the message that they're being given and through the follow-up and success of their pregnancies.
Yeah, I agree. Dr. Spears is going to be back on Tuesday, March 9th, doing a webinar devoted to pregnancy for patients, women with genetic heart diseases. And Danna, before we talk more, give our listeners a sense of who is this person I'm speaking with anyway, called Dr. Spears. Tell us how you got from here to there.
So I'm a cardiologist, electrophysiologist here in Toronto. And I was very fortunate to have completed my training and subsequent large part of my fellowship here. And we do have a large dedicated program to cardiac diseases and pregnancy through the University of Toronto. The main focus of this program for many years has been congenital heart disease and bringing women through pregnancies with congenital heart disease. And something that was really missing in our program was an arrhythmia specialty, and specialty with these inherited heart conditions, because they were very much underrepresented in the group of women that we were looking after. And so when I started here, that became an interest of mine to try to build our program to allow women to go through pregnancy here and have careful cardiac monitoring, genetic testing, the whole sphere of this, and then to ultimately link up with the Hospital for Sick Children so that these babies will then have longitudinal care and follow-up through our pediatric program. And then subsequently, we've had some of them graduate back to the adult program here now. And some of our families are on third generations of children going through our cardiac disease and pregnancy program now.
Wow. That's really I'm wondering on Suzy, for you mentioned that you needed to have a C-section, and Dr. Spears, in hearing that, I suspect that's something for you to comment on a bit, because I encounter this quite frequently of obstetricians largely demanding a C-section because they're now dealing with a genetic heart disease patient, and I have to hit the foul, do the timeout, say, wait a second, if you need to do a C-section, it better be because of your organ, obstetrical criteria, not my organ, the heart. The heart and your long QT syndrome or your CPVT or your whatever is not a reason for a C-section. Do you agree with that? How long has it taken for us to try to get that message to sink in through to the obstetrical community?
Well, Michael, I'm not sure that message has made it through.
Right.
And it's something that I hear a lot. And again, just to reiterate, for cardiac reasons, again, there are very few contraindications to spontaneous delivery. And many women are advised that they will need to have a surgical delivery or instrumented delivery because of their inherited heart condition. There's very sparse data on women going through pregnancy with some of the less common inherited heart conditions. And I think, again, it's this fear of the unknown and the wish for, as us as physicians, for us to control the situation as much as we can, understanding that there may not be a clear indication for a surgical intervention in some of these women. There have been some good publications actually looking at circulating catecholamines during pregnancy, labor, and delivery, and comparing the difference from spontaneous delivery with or without analgesia and delivery with cesarean section. And there's no clear evidence that actually having a surgical delivery is going to have a beneficial effect on some of these cardiac parameters, especially ones that are catecholamine driven. And I'm thinking of CPVT and long QT syndrome as the main ones, where we do our best to restrict catecholamine exposure. But in many cases, a woman who is medically managed and well beta blocked and stable through pregnancy should have no issues going through labor and delivery without a surgical approach. So this is a message that, even it's gone all the way from discussing cesarean section to then looking at women being really pushed into having spinal anesthesia or epidural anesthesia for their delivery. And many women do not want to go that route, or they at least want the option to not have to go that route. And this is a common discussion between myself and our cardiac obstetrics doctors, whether this is necessary and what the evidence is to support pushing this intervention if women really want to explore other options.
Right.
This is an ongoing dialogue between us and the OB community.
Absolutely. And I think another source of ongoing dialogue is the beta blocker dialogue. And Suzy, Dana from Ireland, thanks Dana, is asking about whether you stayed on your beta blocker throughout your pregnancy. And then Danna and I will make some comments about that issue.
Yes, and I just would like to comment on a couple of things that Dr. Spears mentioned. First of all, yes, I did stay on my beta blocker throughout pregnancy, and there was no trouble. Any alterations we made with my care were due to the baby. We were trying to see what we could do to help her out and help out her arrhythmia. And that's a completely different conversation because that's pretty involved. But I did stay on the beta blocker. I never went off of it. And I was able to stay active during my pregnancy the whole time. I went for a walk every single day. I even was able to go to the gym, lifted weights. I would do intervals on the treadmill. I have a pretty high beta blocker dose, so I don't always have the greatest endurance, but pregnancy did not have a great impact on my endurance negatively. I was able to still continue the same level of activity that I always had been able to. So I'm happy to say that. And regarding the C-section conversation, it was for a long time, the conversation was that I did not have to have a C-section. I could try the spontaneous delivery, but as Gabby's heart condition appeared to be a pretty severe form of long QT and her heart block, it was decided that it was much safer for her to have a C-section delivery, and that way we could prepare as well to have all the special children's hospital team there.
Yeah, I think, Suzy, that's a great point, that your C-section was clearly indicated. It was well thought out by a great group of individuals. Shout out to Dr. David Bradley. Great guy. So I think that's the point, is the decision for that C-section wasn't driven by a nervous, concerned obstetrician. It was driven by the concern about the health of the baby and having control over the baby's expression of Gabby's LQT2. So the C-section, I think, like Dr. Spears has said, anybody out there in obstetrical land, please stop doing the C-section just because my patient is diagnosed with long QT syndrome, is the bottom line. On the beta blocker, Danna, oh boy, that's another one that we have work to do, right? What are you observing with with your interactions with obstetricians in beta blocker land? I've seen some horrific mistakes being made with them switching the beta blocker without talking to us, switching them to a beta blocker that doesn't work just because it's OB preferred. What's some of your comments and experiences with the continuation of beta blocker and the right beta blocker throughout your patient's pregnancy?
Yeah, and I think that's an extremely good point. So there is, in the community, there is some concern and resistance about beta blockade in women. And as you know, there's a body of literature usually coming from women with more severe structural heart disease, with concerns about beta blockade and low birth weight probably being the most common concern. And I think it's difficult to tease out the contribution of maternal factors versus beta blocker factors in that very different population. So that's a population that is not one of these primary genetic or inherited arrhythmia conditions. A beta blocker is absolutely indicated in long QT syndrome through pregnancy and postpartum, absolutely. And I think that is a difficult message to get across. I'm very lucky to be at a large cardio obstetric center where it's understood, and there's a great deal of experience with this type of intervention in long QT syndrome. But I have had women who have encountered obstetricians or midwives who would be happy to deliver them as long as they're not on a beta blocker, because they're concerned about the effects of beta blockade on the pregnancy or on the fetus. I'm not quite sure. I find it puzzling and of course frightening that there are women out there who are getting this message. And so for my patients, I think it's very important that they know and that they're educated about the risks of not being on a beta blocker and the benefit of being on a beta blocker and the very low complication rates in terms of neonatal and fetal impact of beta blockade, and that they have to advocate for themselves. And I make it very clear that no one is to touch their beta blocker dosage or type of beta blocker that they're taking without discussing it with me first. And I think that that message, of course, there's always room for this message to be disseminated further into the community. And I agree, it remains an important challenge. Obstetricians have a lot more experience with, for example, labetalol for managing maternal hypertension. But of course, this is not one of the preferred beta blockers for management of these primary arrhythmia conditions. And so trying to make sure that we have a stable level of beta blockade for a woman entering pregnancy, or if we've caught them during pregnancy, to be titrating this dose. Obviously, we're watching baby, looking at fetal heart rate and whatnot for the reasons that Suzy has described, as bradycardia can be a sign of long QT syndrome, not just a beta blockade. Right. And so this is a critical message. And I think if there's any message that we're getting out there, this is probably one of the top 5 of them that women and obstetricians need to know.
Yeah, and I think to summarize that critical one, and then I'm going to have you tell me what do you think are the two other most critical messages as we come towards the top of our hour together. I think what you heard Dr. Spears and I say, so any of our patients where we have put you on the preferred beta blocker of Nadolol or propranolol, do not let an obstetrician change that medicine to metoprolol or atenolol without our direct permission. And just FYI, that obstetrician will never receive that permission from me. So that I have seen tragic deaths of long QT women who were well controlled on their Nadolol, only to have had that beta blocker switched to metoprolol, which is not effective enough, and then have a tragedy occur on our hands that was completely preventable. So if that's one of the critical ones, Dr. Spears, what would be your other two biggies that you would want to make sure everybody is working through? And I'm sure you're going to expand on those on your webinar Tuesday night, but give us a sneak preview of those other two big ones.
Well, I think one of the first ones that we touched upon is that pregnancy is not contraindicated. And so I think that's one of our most important messages, is that this can be very safely and adequately managed in a woman with an inherited heart condition. So pregnancy is not generally, I can't think of many cases where a pregnancy would be contraindicated in one of these heart conditions. Keeping in touch with your cardiologist through your pregnancy and creating this ability for communication between the obstetrician and the cardiologist for both education and support purposes is also incredibly important. So staying on your beta blocker and not changing it, as Dr. Ackerman has said. And then, the third important message is another one that we've talked about, is the role of obstetric intervention. And so for cardiac purposes, again, if you're looking at maternal indicators for a cesarean section, very few of them appear in this population. And of course, if there are obstetric or fetal issues that need to be addressed, that may be different. But from a maternal perspective, there's rarely an indication for a purely surgical approach to delivery. And then I think something that I have encountered a lot in women through pregnancy is that feeling that their choice has been taken from them in terms of mode of delivery, in terms of level of analgesia, or how they want to approach this. And again, I think it's important to have a message to both women and obstetricians that this is a partnership in care. And if you're not, if you have questions or you're not comfortable with the heart condition that you're dealing with, there's a lot of support out there in terms of consultation to get women through successful pregnancy safely. You don't have to come to Toronto to deliver. You don't have to deliver at the Mayo Clinic. We've managed deliveries throughout our province, through Northern Ontario, and through quite remote communities. We've managed to support women through pregnancy. And it's just a matter of being aware of the resources out there and using them. And for women, of course, sometimes you have to advocate a little bit for yourself if your caregivers aren't aware of what is out there in terms of support for them. And to seek this information and to seek consultation with specialists to work with them.
Great, so well said. I have one more for you, Dr. Spears, and then I'm going to give the last to you, Suzy, because it's a question brought by Samantha that's so good. But before we get to the final one, I wonder your thoughts, Danna, on whether our moms should be called high-risk pregnancies. I don't classify them as that. I know others have advocated for that. I think that designation has backfired because I think it has made the sense that this is somehow spooky, precarious, dangerous, all heck is going to break loose, so on. And I think there's a methodical drill that you just beautifully outlined that can happen without labeling them a high-risk maternal fetal medicine pregnancy. What's your thoughts in your program? Do you label them as that? I'm curious.
No, and I agree with you. And so we actually don't call our program, a high-risk cardio obstetrics program. It's just the special pregnancy program, or the cardiac problems in pregnancy program, because we do, obviously there are some women who are not part of this particular group who are high risk within our division. But in general, no, these women should, I think it's damaging to be labeling them as a high-risk pregnancy. There are certain features of the pregnancy that are unique that need to be taken care of. But in terms of being high risk, no, I think the vast majority of women in this category should not be considered a high-risk pregnancy.
Right. And then I got to ask you one more, Danna, because several have been asking it on the sidebar. We touched on beta blocker, but what about for our CPVT moms quickly on flecainide? Several have asked, are they supposed to stop their flecainide during their pregnancy? Is flecainide of concern to the mom or the developing baby?
No, we use flecainide in pregnancy frequently. Flecainide is also used for the management of fetal arrhythmias in utero, so given in higher doses to mom to manage fetal arrhythmias. So we do not stop flecainide during pregnancy. In fact, there have been times where I've introduced flecainide during pregnancy for arrhythmia management. And I think that the important message that we've been giving here is that when you've been stabilized and managed on your nadolol, propranolol, or a combination with nadolol and flecainide, it's not the right time, I don't think, to start making huge adjustments and discontinuing medications if you're stable on those agents. So I do not recommend that those be discontinued.
Great. I wanted to make sure we got that in because I saw that come through more than once. But the final one, and this I turn to Samantha's question, and it's such a good one, Samantha. It is asked to me or posed to me by so many young women, and that is the question of, I can't pass this on to my child. Therefore, I don't want to have a baby. And there's probably a lot to deal with in that 3 minutes, but she's wondering if you could speak about having a child that you knew had a 50-50 chance of getting your long QT, and then that baby experiencing a more pronounced, difficult expressivity of your long QT than you did, because yours was pretty tame in your body. And was that difficult? And were you aware that the behavior in a child you created might not be as tame as it had been in you, that it might be worse? And how did that play into whether or not you ought to become a mom naturally with the possible risk of passing this on to your child?
I love that question too. And I just want to correct you. My expressivity is actually rather severe, but I'm really well managed. I haven't had an episode, I think, because I've had kind of a perfect cocktail of my device and my beta blocker dosage. So Gabby actually ended up, I too was born with a heart block with my my long QT, and I had a pretty long QT interval. The difference is Gabby did seem to have a longer QT interval. She was in the 700s when she was born. And so that got everyone pretty excited. And we were able to anticipate that, though, because of the research study we participated in, that it could be pretty severe. To that question of basically how did I come to this? It's such a great question. I still grapple with that question about how I feel passing it on. For a very long time, actually, I wasn't comfortable with it at all. And it took me a long time to come to the point where I felt the urge to start a family stronger than how worried I was about passing on this genetic condition. One of the ways I actually felt more comfortable with my decision was the opportunity to talk to other moms in the SADS Foundation who were really, really, really generous with sharing their experiences with me. And one I call a friend now because she was able to share her experience and her decision-making process and her personal past with it. So it's hard having Gabby have a pretty severe variant of it and seeing all the medical intervention she's already had to have in her 10-month lifespan. And it's definitely a full-time occupation at this point to help her out and take her to her appointments. But she's pretty great. I really like her, and we're glad we have her.
I'm so glad you joined me, Suzy, and hear your story and your pregnancy and delivery and the birth of a complicated but a beautiful baby girl, Gabby. And so thank you for that, Suzy. And Dr. Danna Spears, thank you. Danna, would you want to touch on that whole realm in a couple of thoughts, and then I'll wrap up?
Yeah, this is a question. We do a lot of pre-pregnancy counseling and talk about the inheritance, and I think it's important to recognize how successful medical management of these conditions has been. So, women and children are living relatively full lives and accomplishing the things that they aspire to. It's a few more doctor's appointments and some medical therapy in many of these cases. But I don't think anyone would deny that these women and babies are living full and extraordinary lives, and that this is not something that should bar a pregnancy decision. In rare cases, we have women choosing pre-implantation genetic testing and kind of going further down that route. But to be honest, with long QT syndrome, that is something that has not come up because it is so manageable and successfully manageable.
Yeah, and I think, yes, that is available, that being pre-implantation genetic testing, but almost never utilized. We've done it 5 times in 20 years of all of my women, and I think for all of the young moms and the to-be moms out there, Dr. Spears and I have had the privilege of taking care of many, many beautiful babies born to dads and moms where one of the parents had long QT syndrome or CPVT or Brugada or HCM. And half of those babies have their family's genetic heart disease, half do not. And they have been beautiful children. And so my final word to you would be, if you don't want to have a family, that's fine. There may be reasons not to become a mom or dad naturally, but your heart reason should not be the reason. That your genetic heart condition should not. And if you have anybody anytime tell you don't become a mom or don't become a dad because of your genetic heart condition, that individual is not worth your hearing time, because you can and you should, and it will be an amazing journey. There is very few things greater than being a mom or a dad, maybe being a granddad. My granddaughter is 13 months old, as you know. So, Suzy, thank you. Dr. Spears, this has been wonderful. I hope everybody will join Dr. Spears Tuesday night, March 9th, 7:30 p.m. Eastern, and return with me a week from today, same time, same channel, for SADS Facebook Live number 55 on March 12th with the author, Catherine Standifer. And you're gonna love this. I have to read her book between now and next week, so I'm ready for that. But I hope everybody has enjoyed this. I think this has been a very special episode, special really because of you, Suzy. Thank you. And you, Dr. Spears, thank you so very much, and have a wonderful weekend, everyone. See you next week.
Take care.
Thank you very much.